So I will discuss something that how we can manage this pain with our patient. Okay. So I've been sponsored by Pharma Research, and I have 182 papers now, and a few editors in Polymers scientific reports. So we want to make a face useful, right? In 20s, we don't have wrinkles, furrows, or fat sagging, but we do in 80s. But we are not trying to get back into 20s, but we want to make it very natural, very useful way in using this kind of skin boosters, fillers, and toxins. And I want to say that polynucleotide is the most naturalistic way of using to make a face more useful. So nowadays we are using polynucleotide for dermal area, right? So dermal area, we got to know the thickness, the average thickness of ethnicity, Caucasians are thinner, and when we get old, we get thinner and thinner, and for women, they get dramatic loss of dermal thickness after menopause, and males are thicker than the woman. So all this matters when we do injection of polynucleotides. Okay, what is DOTPN? So DOTPN is one of the skin boosters, and skin booster, the term came from Wrestling Vital Skin Booster in 2015 from Galderma. And after that, we are using this term skin boosters and classified into several categories, and polymers, amino acid, and all that. So we classified polynucleotide as one of the sub classification. And not only with the material itself, but we can classify these skin boosters in giving a signaling way, or it gives us ingredient to make more cell proliferation, or the environmental that it gives to make cell to work in better place. And also we can classify these skin boosters in a way of anti-inflammation and a way of inflammatory skin boosters. Like for the polymers, they, for example, like PLLAs, they activate. We are trying to make the inflammation, which is mild and general, and that is what we are looking for. And when you go on that side, the more adverse effect that can happen. Nodules, granulomas, hyperinflammation. But when you go in the side of polynucleotides, there are much less chance of having this adverse effect. So that is why we are prone to use this DOTPN, right? And also, when you use the skin boosters, more of the foods there are, there will be more of a fibroblast that's gonna be gathering at that place. So more food, more of better dermal conditioning. And why we have to use something that is injectable is because general skin boosters that we want to put into the dermal layer, they are not, they don't meet these rules, like 500 Dalton rule, lipolytic. The size also matters. So when we consider all this kind of stuff, we gotta put them in the dermal layer with a mechanical injection, or like a micro needling or something. With using just sonophoresis or electrophoresis, it's not gonna be really effective. All of polynucleotide and the good stuff will be much of a loss than it actually goes into the dermal layer. So, and one thing that we have to consider is the lasting time, like volumizing effect, stretching effect that gives. So when DOTPN is injected intradermally, they will stretch the nearby fibroblast and stimulate them. But as of previous publication, when the stretching effect lasts too long, it gives a bad, poor regeneration. So that is why we don't want this skin boosters, which has been injected, to last too long. And I think this is the really strength of the polynucleotide of which run, because they don't last long, but they efficiently stretch the fibroblasts nearby, and also they are breaking down into DNA particles, which gives a food to regenerate, right? And also the DOTPN, it has the structure of hexagonal, and that gives a very slow, long effect of skin boosters. They break down, and also, as Dr. Chu told us, it's not only we are not targeting only dermal layer, but we are trying to put them in the adipocytes, like fatty tissues, SMAS layer, muscles, and we have few papers, few evidences that they do stimulate pre-adipocytes and to proliferate and make a volumization effect, very natural volumization. So these are the papers that we have published, and definitely we use the vigilance scar, which is higher viscosity, and the strength of the this hexagonal structure is they are light, and they are strong, and they give a scaffold effect too. So our fibroblast is much bigger in size, so they won't go into the this hexagonal layer, but they would go degraded from the surface of the bolus injection of the polynucleotides. And it can also be used as a delivery vehicle, and we can. That is the reason why we do a combination with the PRPs and toxins. When you combine a toxin with polynucleotides, the effect, the benefits are they spread slow. Okay, so when you do solely a toxin into a person, they might feel very uncomfortable because they just cannot use the muscle they used to. But when you do this kind of combination therapy and put this toxin into the cells the polynucleotide have, it will, the effect will be very gradual, so that the patient won't feel the discomfort at just action of the toxin. Then I'm going to talk about a little bit of the aging process of the fat tissues. Some people say superficial fats, they don't atrophy, but they only do migration. But in my thoughts, because they all come from the stem cells, and when we age, the stem cells, they deactivate. So superficial fat tissues, they tend to more migrate than atrophy, the volume loss. But the deep fats, they are more of a volume loss as we get aged. Okay, and when we do skin removal in the and reveal the superficial fat, they are not actually divided in that way. They are like a whole chunk of the fat tissues, but they do have when you see the histological section, they are divided into some of the compartments. So this type of superficial type of fat will not go into a natural level fat as we get age. Within the compartment, they tend to show a migration towards the medial and inferiorly. Okay, so that is when we can use volume losses in the areas, and that is where we can do a polynucleotide injection to make it soothed, very bulky contouring of the face. And what you gotta know is that foreheads, they don't change that much as we get age. So more focus in volumization with the polynucleotide should be on the mid or low face. Because the forehead, the fat tissues are not thick enough. they are less than 1 centimeters. And also the bony structure on the forehead, they don't change that much compared to mid-face and lower face. So the proportion changes as aging, that we get more of a lower face in volume-wise. And when we do a dissection in very elderly cadavers, we see a volume of fat accumulation in above the mesolevel for the marionette line. And Dr. Cho told us that we do a regional eye injection in the infraorbital area is because that polynucleotide seems to stimulate pre-adipocytes. And you gotta know, infraorbital area, they have a very shallow superficial fat tissues. And as we, when we dissect the elderly cadavers, we don't see much of the fat tissue in the infraorbital region. So that is why we get dark circles that is penetrated by the orbicularis oculi muscle. So we want to make it in the superficial subdermal injection of the iris run in to stimulate these adipocytes. Okay. So previously we divided skin type into type 1 and type 2. Type 1 is layer by layer, and type 2 is not layer by layer. But I divided it into more specific way. Type 2A muscle fibers, they directly insert to the dermal layer. Type 2B, the muscle fiber turns into collagenous fiber, then attached to the dermal layer. And type 2C is the two ligament comes from periosteal layer to the dermal layer. And type 2D is from the sparse or muscle layer to the dermal layer. These type 2 are the barriers for fat migrations. So superficial fat tissues, they are blocked and compartmentalized by this blockage. Okay. So orbicularis, retaining ligament, tear trough muscles, they are the type 2 that makes very student control of the face. So this orbicularis oculi muscle, some parts, they attach to the dermal layer. That is why we get more prominent tear trough muscle. Since we get a shorter contracted muscle as we get age, and also the superficial fat tissues that was covering over the tear trough muscle is disappeared. Okay, so